Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 427 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, PDA, a 35-year-old man with stage 4 Hodgkin lymphoma, is receiving ABVD, that is doxorubicin 25 mg per meter squared IV days 1, 15, bleomycin 10 units per meter squared IV on days 1, 15, vinblastine 6 mg per meter squared IV on days 1, 15, and dacarbazine 375 mg per meter squared IV on days 1 and 15, and concurrent radiation therapy to a large mediastinal mass. He comes to the clinic to receive his 5th cycle of ABVD and complains of tachycardia, shortness of breath, and a non-productive cough. Physical examination reveals neck vein distension, pulmonary rales, and ankle edema. Past medical history is significant for controlled hypertension. So my question to you reads, what is the most likely cause of PDA's current symptoms? PDA is experiencing symptoms of congestive heart failure most likely caused by doxorubicin therapy. Doxorubicin, an anthracycline, can cause a dose-dependent cardiomyopathy that generally occurs with repeated administration. Doxorubicin causes myocyte damage by a mechanism that differs from its cytotoxic effect on tumor cells. Because myocytes stop dividing in infancy, they presumably would not be affected by an agent whose cytotoxicity relies on actively cycling cells. Many mechanisms have been proposed to explain the cardiac toxicity associated with anthracyclines, including the formation of reactive oxygen species. The association of anthracycline-induced cardiotoxicity with other agents administered concomitantly, monitoring techniques, and therapies to prevent and treat this condition have been reviewed. PDA's presentation is fairly typical of doxorubicin-induced cardiomyopathy, although he has no significant risk factors usually associated with congestive heart failure. The total cumulative dose of doxorubicin is the most clearly established risk factor for congestive heart failure. Patients, such as PDA, who are receiving bolus doses of doxorubicin at the standard 3-week interval face little risk of congestive heart failure until a total dose of 450 to 550 mg per meter squared has been reached. After a patient has received a total dose greater than 550 mg per meter squared, the risk of congestive heart failure rises rapidly. Patients receiving less than 550 mg per meter squared of doxorubicin face a 0.1% to 1.2% risk of experiencing congestive heart failure. Comparatively, patients receiving greater than 550 mg per meter squared face a risk that rises more or less linearly. The probability of congestive heart failure in patients receiving a total dose of 1000 per meter squared may be nearly 50%. Other factors that could increase PDA's risk of experiencing doxorubicin cardiomyopathy include mediastinal radiation therapy, pre-existing cardiac disease, and hypertension. Young children, as well as older patients, are likely to experience congestive heart failure at a lower cumulative dose. Concurrent chemotherapy agents, e.g., cyclophosphamide, etoposide, mitomycin, melphalan, trastuzumab, paclitaxel, vincristine, and bleomycin, may also potentiate doxorubicin cardiac toxicity. When patients receive paclitaxel and doxorubicin, the risk of cardiac toxicity appears to be related to the sequence and proximity of the infusions. In a pharmacokinetic study, paclitaxel increased the area under the curve of doxorubicin and its active metabolite, doxorubicinol, when paclitaxel administration immediately preceded doxorubicin. Therefore, doxorubicin should be given at least 30 minutes before paclitaxel. The relationship between risk factors and the total cumulative dose of doxorubicin is sufficiently strong to warrant guidelines restricting the total cumulative dose of doxorubicin to 450 mg per meter squared in patients with one or more identified risk factors, including mediastinal radiation, elderly age, and pre-existing cardiovascular disease, high-risk patients, and to 550 mg per meter squared in patients without any of these aforementioned risk factors, low-risk patients. It is unusual that PDA, a 35-year-old man who has received a cumulative dose of only 200 mg per meter squared of doxorubicin, would be presenting with symptoms of congestive heart failure. Mediastinal radiation therapy, or an undiagnosed cardiac disease may, however, have contributed to this event. In addition, Hodgkin lymphoma involving the myocardium may be responsible for this presentation. My next question to you reads: should PDA receive routine cardiac monitoring while he is receiving doxorubicin? Doxorubicin prevention of cardiomyopathy is achieved primarily by limiting the total cumulative dose. Limiting the total dose, however, cannot entirely prevent the cardiomyopathy for two reasons. First, individual tolerance to doxorubicin varies such that cardiotoxicity may occur before the arbitrary dose limit. Second, some clinical situations warrant exceeding the dose limit to achieve positive chemotherapeutic outcomes. Early efforts to prevent cardiomyopathy focused on monitoring systolic time intervals, QRS voltage loss, or STT segment changes on an electrocardiogram. These changes were too nonspecific or occurred too late to be useful. However, serial echocardiography, abbreviated as ECHO, has been useful. Current monitoring for anthracycline cardiomyopathy includes assessment of a patient's left ventricular ejection fraction, abbreviated as LVEF, which is a measure of the heart's systolic function by echo, radionuclide cardiac angiography, multiple gated acquisition, abbreviated as MUGA, or endomyocardial biopsy. The use of multiple gated acquisition for early detection of doxorubicin-induced cardiac dysfunction has been investigated extensively. A multiple gated acquisition can accurately detect functional cardiac status, but it is not particularly sensitive in detecting patients who have early myocyte damage. Augmenting the multiple gated acquisition with exercise appears to give a more accurate picture of functional cardiac reserve. Because myocyte damage usually occurs days to weeks after treatment with doxorubicin, the multiple gated acquisition should be obtained just before, rather than just after, a course of the agent. Although guidelines vary, most suggest regular cardiac function assessment by evaluation of left ventricular ejection fraction by either echo or multiple gated acquisition. PDA should have received a baseline assessment of his left ventricular ejection fraction either by echo or multiple gated acquisition before his first cycle of ABVD. During courses of therapy, left ventricular ejection fraction monitoring for PDA would not have been routinely recommended unless he was approaching his lifetime cumulative dose or there were clinical signs or symptoms of congestive heart failure. Because PDA presented before his fifth cycle of ABVD with symptoms of congestive heart failure, another echo should be performed, and his doxorubicin should be discontinued. Additional assessments should be obtained when a patient shows signs or symptoms of congestive heart failure or when low-risk patients receive cumulative doxorubicin doses greater than 450 mg per meter squared or high-risk patients receive greater than 350 mg per meter squared, if additional doses are planned. Most guidelines recommend stopping doxorubicin or obtaining an endomyocardial biopsy when there is an absolute decrease in the left ventricular ejection fraction of greater than 10% to 20%. The left ventricular ejection fraction is less than 40%, or the left ventricular ejection fraction fails to increase greater than 5% with exercise. Endomyocardial biopsies, along with a quantitative assessment of morphologic changes, provide the most specific evaluation of myocardial damage induced by anthracyclines. Progressive myocardial pathology is graded on a scale, the Billingham score, of 0 that is, no change from normal, to 3, that is diffuse cell damage in more than 35% of total number of cells with marked change in cardiac ultrastructure. Abnormal multiple gated acquisition findings and the appearance of signs and symptoms of congestive heart failure correlate with biopsy scores. Usually, a significant change in cardiac function is not seen with scores less than 2 to 2.5. Several investigators have evaluated the predictive value of this technique. With a score of 2, a patient has less than a 10% chance of experiencing heart failure if 100 mg more of doxorubicin is given. The most significant risk associated with endomyocardial biopsy is perforation of the right ventricle with associated tamponade. This occurs rarely and depends largely on the experience of the individual performing the biopsy. We will now look at other anthracyclines. Daunorubicin differs structurally from doxorubicin only by hydroxylation of the 14th carbon. Cardiac toxicities are similar for both drugs, although somewhat higher cumulative doses of daunorubicin are typically tolerated. Although idarubicin appears less cardiotoxic than doxorubicin in animal models and daunorubicin in some early clinical trials, other studies show equivalent myelosuppressive doses can cause cardiotoxicity comparable to that of doxorubicin and daunorubicin. Epirubicin also has an incidence of demonstrated congestive heart failure. For all of the agents in the anthracycline class, risk factors for congestive heart failure appear to be the same, and similar assessments should be undertaken to monitor for cardiotoxicity. Mitaxantrone is an anthracendian that is structurally similar to the anthracyclines. Guidelines for monitoring doxorubicin-induced cardiotoxicity should also be followed with mitoxantrone therapy to minimize the risk for congestive heart failure. My next question to you reads: could PDA's congestive heart failure be prevented by the use of a different dose or dosing schedule or by an agent that protects the myocardium? Altering the dose schedule of doxorubicin to more frequent, smaller doses while maintaining dose intensity has consistently resulted in reduction of cardiotoxicity without obvious compromise of anti-tumor effects. Several reports suggest that peak plasma levels, as well as cumulative dose, have an important relationship to doxorubicin cardiotoxicity. Low doses of doxorubicin administered weekly or prolonged continuous IV infusions, that is 48 to 96 hours, can be relatively cardiac sparing, allowing higher cumulative doses to be administered. In a retrospective, uncontrolled study of 1,000 patients receiving weekly doxorubicin, a total dose of 900 to 1,200 mg per meter squared of doxorubicin given in weekly fractions had the equivalent cardiotoxicity of 550 mg per meter squared given in every 3-week fractions. Although well-designed studies comparing cardiac toxicity after bolus doses with fractionated therapy or continuous infusion are lacking, treatment that incorporates these alternative schedules should be considered in patients with pre-existing risk factors who will be receiving doses greater than 450 mg per meter squared or in patients without risk factors who will be receiving doses greater than 550 mg per meter squared. In patients with pre-existing congestive heart failure or those who have exhibited congestive heart failure, a continuous infusion schedule of anthracyclines rather than bolus doses may be considered. The concurrent use of drugs that might minimize the risk of cardiotoxicity without compromising efficacy can be considered as well. Dexrazoxane is a chemoprotectant that reduces the incidence and severity of cardiomyopathy. It is indicated in women with metastatic breast cancer, who have received a cumulative doxorubicin dose of 300 mg per meter squared. The recommended dosing ratio of dexrazoxane to doxorubicin is 10:1 slow IV push 30 minutes before starting doxorubicin. Currently, the ASCO guidelines do not support the routine use of dexrazoxane in patients, unless a plan exists to continue doxorubicin beyond a total cumulative dose greater than 300 mg per meter squared. Clinical trials have evaluated the benefits of dexrazoxane in children and patients receiving other anthracyclines. A meta-analysis including 10 trials with a total of 1,619 patients evaluated the use of dexrazoxane in anthracycline therapy and observed a decreased risk of clinical heart failure, relative risk 0.18, with a confidence interval of 0.1 to 0.32, with a p-value less than 0.001. But there was no effect on overall survival. Despite data suggesting cardioprotection with the use of dexrazoxane, it is not used routinely. Concerns exist about a possible decrease in efficacy of anthracyclines with its use as well as the potential for an increase in secondary leukemias. In the meta-analysis, there was no difference in tumor response rate reported and toxicities attributed to dexrazoxane only included an increased frequency of risk of neutropenia that resolved with count recovery. To reduce cardiotoxicity, Doxorubicin that is encapsulated in liposomes can be given instead. A phase 3 trial of women, N equal to 509, with metastatic breast cancer showed that efficacy with liposomal pegylated doxorubicin may be similar to conventional doxorubicin with decreased cardiotoxicity. A review and meta-analysis of 55 randomized control trials in patients receiving anthracyclines showed that the risk of cardiotoxicity was significantly decreased with liposomal doxorubicin versus conventional doxorubicin. Odds ratio 0.18 with a 95% confidence interval of 0.08 to 0.38. The majority of patients were women with advanced breast cancer. Despite reduced cardiotoxicity, liposomal doxorubicin has not replaced standard doxorubicin in current treatment regimens secondary to high cost and lack of evidence showing equivalency. An established equivalent dose of liposomal preparations to conventional doxorubicin is not confirmed and is variable depending on the disease state and regimen. PDA's congestive heart failure may have been prevented with continuous infusion doxorubicin or the use of dexrazoxane. However, because he had not approached a cumulative dose that warranted alternative strategies, this would not have been part of the standard management plan for a patient receiving their first several cycles of ABVD. My next question to you reads: how should PDA's doxorubicin-induced congestive heart failure be managed clinically? Anthracyclines-induced congestive heart failure presents similarly to other forms of biventricular congestive heart failure and occurs between 0 and 231 days after the last dose of doxorubicin, with a mean of 33 days. Anthracycline-induced congestive heart failure should be treated with a similar approach to cardiomyopathy induced by other means. Often these measures are ineffective. The clinical course varies, with some patients showing stable disease and others showing improvement. Before cardiotoxicity was a widely recognized toxicity, the course of anthracycline-induced congestive heart failure was characterized by a rapid progression that generally led to death in a few weeks. The clinical outcome is better now, likely because anthracycline therapy is promptly discontinued after initial presentation and there are better treatments for congestive heart failure. These include the use of spironolactone, beta blockers, angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, and diuretics, which have decreased morbidity and mortality in non-anthracycline-induced congestive heart failure. Enalapril was evaluated to determine whether it would prevent cardiac function decline in a randomized, double-blind, placebo-controlled study of pediatric cancer patients who were at least 2 years out from treatment with anthracyclines and had evidence of congestive heart failure. Patients received enalapril at 0.05 mg per kilogram per day, and this dose was progressively escalated to 0.10 mg per kilogram per day, and finally 0.15 mg per kilogram per day if there were no side effects. Although enalapril did not increase exercise intolerance, it did increase left ventricular end systolic wall stress in the first year of treatment. Side effects included dizziness, hypotension, and fatigue. An additional trial evaluated 201 patients with anthracycline-induced cardiomyopathy. Enalapril and carvedilol were initiated as tolerated as soon as left ventricular ejection fraction impairment was observed. Complete resolution of congestive heart failure was observed in 85, that is 42%, of patients, and an additional 26, that is 13%, demonstrated a partial response. Patients who had heart failure therapy initiated closer to the time of observation of their left ventricular ejection fraction impairment had better response. No responses were observed in patients who had heart failure therapy initiated greater than 6 months from the end of their anthracycline regimen. PDA's cardiomyopathy should be managed conservatively with an angiotensin-converting enzyme inhibitor such as enalapril and fluid restriction with the addition of diuretics as necessary. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 428.